Thanks very much. Here we go, gloves off. So historically, certainly endarterectomy has been the gold standard. Why is that? Well, it's traditionally pretty easy surgery with stellar results and quite excellent durability. It's also traditionally been a so-called no stent zone. Why is that? Well, it's always been the center point of our surgical world. It is a flexion point, and there's always been concerns about the impact on future endo interventions. We teach our trainees in the vascular surgical world that this is hollow ground, and this is an often quoted statement, where goes the profunda, there goes the leg. There is certainly concerns that this dictum is being lost in the current endovascular enthusiasm. Why is it so good? Well, it's versatile, and if one does a good job, one can remove a significant amount of plaque from the external iliac. You can go down the entire profunda. You can go to the proximal SFA, and it's useful in a whole series of scenarios. This is a typical depiction of the plaque removed. This is a patient that I did an endarterectomy on years ago. I've learned the hard way that if you have a big patch, the risk of restenosis approaches zero. This is the same patient treating the contralateral side. So what does the data show? Well, again, historically been a very low-risk elective operation. This is a paper out of Cornell a number of years ago, 1,500 patients, a mortality rate of 1.5%, with a surgical site infection rate in this series of about 6% and a low rate of systemic complications. Lots of different papers I could have called, but this is kind of the hallmark paper. This is out of MGH in 2013. 100% technical success with an endarterectomy, a length of stay of about 3 days, 70% 5-year survival, but outstanding results. No mortality, no amputation, and an assisted primary patency rate of 5 years of 100%. Anything like this typically raises some eyebrows and a lot of skepticism. I completely agree with this because it matches my own clinical experience. On the endo side of things, there's some data flaws. There are a lot of single-center retrospective studies, limited statistical analysis, limited follow-up. This is a smattering of some. I've collated them. You see primary patency rates ranging from 80% to about 94% with the TLR rates that you see. The larger study was was a VQI study of 1,000 patients. I'll highlight that a little bit more. 72,000 patients total. Out of that, 1,000 were called. Importantly, 50% had a prior PVI, and this is the experience that we have. Most were claudicants, most got angioplasty, some got stents, and the 1-year primary patency rate was 83%. The conclusions of these authors was that interventions have a low rate of perioperative morbidity and mortality. Stent use is associated with reinterventions and amputation and should be avoided if possible. This is a very important point. And patency is lower than historical controls compared with endarterectomy. We all know the pitfalls of stent placement and the risk of restenosis and the increasing prevalence that we see. What about some recent endo data? This is a paper published earlier this year in JVS. 100 patients comparing drug-eluting balloons to endarterectomy, 40 and 60. 2-year primary patency rates, as you see, the drug-eluting balloons, 60% versus 94%. 2-year freedom from TLR, 57% versus 94%, so not very good. This is a meta-analysis out of Yale, 7 endo open papers versus 4 endovascular studies, similar survival. And their conclusion, there's little data to support endovascular treatment of isolated common femoral atherosclerosis, and this is coming from a very aggressive endovascular author. What about the VMI CFA study? You're about to hear about this. 100 patients, 2 years of follow-up. They looked at the Abbott Superior stent in Rutherford, 2 to 4 patients. 1-year and 2-year primary patency rates of 93% and 2-year freedom from TLR, 97.8. Pretty good results. A couple of questions I have, though. What was the nature of the follow-up? This is a 2-year study, and I'm curious, what was the follow-up after the first year? Was it phone follow-up? And if so, how do you determine patency and how do you determine TLR? Who decided on TLR and on what basis? A plea to the general world, can we please get rid of TLR for lower extremity studies? It's completely subjective and quite flawed. This is taken off the dark web. This is the exclusion, and you can see the limited kind of morbidity of the lesions selected. This is also taken from the same slide set, and you can see the lead author or the lead PI of the trial does have a conflict of interest, and I think it's an open question whether sponsor bias plays any role. If I can't appeal to the academic merits, I'll appeal to your emotion. Eminent domain. First came the carotid, then came for the legs, then you came for aortic aneurysms. Now you're coming after our surgical soul. In conclusion, technical success is necessary but not sufficient. Just because you can Doesn't mean you should. Vascular treatment failure in PAD carries consequences. Stent thrombosis can be catastrophic, particularly in a claudicant. It's imperative to preserve the integrity of the profunda. If a good operative candidate, find a surgeon who knows how to do the operation. If you can't find one, keep looking. Clearly a role for endovascular treatment of the CFA, but it still does not represent the gold standard. Thanks very much.
Thanks. Thanks, Matt.